Thank you. And Richard, I've got my timer. I'm going to put it on. No, I find it very helpful, and it was fantastic to be here and listen to your talk and think about the things that we don't get explicitly told about. So I think hopefully that's helping a lot of people. So thank you for inviting me today. I'm going to talk to you a little bit about life as a clinician scientist because it is a privilege, but there is quite a lot of pain along the way, and I think it's good to be honest about this as well. So a little bit about me. I was born in 1968, and when I was 11, I saw a film called Sybil, starring Sally Field. Has anyone seen that film? No, you're all a lot younger than me, but she was this young woman here who had multiple personality disorder because she'd actually been abused by her mother. But she had a female psychiatrist who cured her. So I decided I was going to do medicine and be a psychiatrist. But I got 4 A's and I got a C for general maths. So maths has never been my strong point. I thought, oh my goodness, I had in my mind I had to go to Melbourne University, and that meant I had to go up the road to Monash University, which actually was one of the best things because I met some fabulous colleagues and friends, and that's been really helpful to me, particularly in my life as a mother, trying to balance life as a clinician scientist. So I graduated medicine in 1991, and I went to the Alfred and did my internship, and I looked around and I thought everyone is so old here. So this is my paediatric bias that you'll see. And if you look at how much money we spend in Australian healthcare, something like a third of it is spent on the last 3 years of life. And for me, that's a real problem. So I was wanting to be a child psychiatrist, but I found out you had to do adult psychiatry, and I didn't want to do that, so I decided I'd do paediatrics. So I started my career at the Royal Children's Hospital in 1993. And I really enjoyed paediatric training. I enjoyed the clinical experience, but I felt it was not enough. As a clinician, you can see one patient at a time and help them, and that is really, really important. However, doing research, you can help hundreds or thousands potentially at a time. So in those days, you could do your MD, your medical doctorate, in the last 2 years of your advanced training. And I was very lucky to have two key mentors as supervisors, Professor Melissa Wake and Professor Frank Oberklage. So Frank at the time was a paediatrician. He was director of the Centre for Community Child Health. He'd worked in Boston and come back. And I went to him and said, I think I want to do research. And he said to me, do you want to go home with your briefcase empty or full? Do you want a career or do you want a job? And obviously, if you do academia, you go home with a full briefcase, but you're on a career. And I look at my colleagues now who are 25, 30 years into clinical practice, and they're all burning out. They're all actually pretty bored with what they're doing. And I'm not bored, and I've never been bored because I've had the privilege of being a clinician researcher. Frank also had a really good bird's eye view of health. He looked beyond the hospital walls, he looked into the community, and he was really well, and still is really well connected politically. At that time, I was with my now husband, but we hadn't got married, but I looked around and said, who is in a position of leadership at the Royal Children's Hospital who has a family and has a partner? And the only person I could find was Melissa Wake. It's changed a lot now. So I went to her said I want to do research, and she just had this list of ideas for doing a PhD or an MD, and I chose this topic here to look at the impact of an infant sleep intervention on postnatal depression and as a randomised controlled trial. So I started my MD, and this was the first RCT in the world that looked to see whether a sleep intervention for babies could not only improve sleep in babies, but postnatal depression in mothers. And I went out into the community. I went to maternal and child health centres, and I recruited 156 families, randomised half of them to getting the intervention or not. I delivered the sleep intervention. It worked. We published in the BMJ. I got a college award, and I just thought research and publishing was easy. So that was my very naive beginning of being a clinician researcher. But Melissa taught me one of my first key takeaways. You need to think about scale of your research. So I had done what we call an efficacy randomised controlled trial with me delivering the intervention. But that doesn't help the hundreds to thousands of mothers that are trying to manage sleep problems every year in Australia or internationally. So she said to me, who else? Who is the workforce who deals with mums in Victoria? And it's the maternal and child health nurses. They offer free universal health care. So I said, okay, I was about to have my first baby. There's nothing like a deadline, a biological deadline to get your grant in. So she said, let's write a grant, an NHMRC project grant, and see if you can take your efficacy trial into an effectiveness trial with maternal and child health nurses. So that was my first grant I ever wrote, and I got it. And again, I thought funding's easy, which is pretty naive. And we ran the trial, and I trained the nurses to deliver the intervention. And here's my second really important takeaway for randomised controlled trials, and that's make friends with a health economist. Has anyone here got a health economist that they work with? Ingrid, yeah, go and find them and make friends with them. So when we ran this intervention, again, we showed the intervention worked, but the key was the health economist looked at cost savings to the Victorian government. And through a 2-session intervention, we stopped a lot of mums going to the residential parenting centres in Victoria, which cost around $1,000 a day. So we saved money to the Victorian government. And because of that, they then funded me to train all 1,200 nurses in the infant sleep intervention. They also funded me to do online training modules for this, which still persists, 10 years later. And they also funded translation of all those parents' resources into 8 different languages. If I didn't have the health economist, I wouldn't have got that translation impact. So for the next 15 years, I balanced my clinical work with randomised controlled trials. And I've worked in public and private, and I still work in private. I set up the Unsettled Babies Clinic at the Children's Hospital, so the Crying Mothers, Crying Babies Clinic and Crying Fathers Clinic, actually. And we ran research out of that. And that wasn't big randomised controlled trials, but we were looking at things like, as parents, what interventions matter to you that could then form prevention, early intervention focus at large in the community. And I started doing work around that. I did a lot of work in sleep, but then I started looking at mental health and behavioural problems and food allergy, and they were all in the community, involving paediatricians, nurses, psychologists, GPs, and always with a health economist. I looked at trials of sleep problems in school kids, again with school nurses, in children with ADHD, in children with autism. And then I started to get, obviously, if you start doing the first RCTs of their kind in the world, you get noticed internationally, you start to work with international collaborators. I also established and led Australia's only paediatric practice-based research network. And this was for private paediatricians working out there in practice who wanted to contribute to research but were never going to be able to write trials or run big programs. So we established the Australian Paediatric Research Network, and I ran some of my trials nationally through them. But we also did the first ever national audits of what do paediatricians see in their practice. And 7 out of 10 children who come to see a paediatrician, and we look after birth to 18 years, it's for developmental and behavioural and mental health problems. So that really got me interested in mental health. And mental health and physical health are inextricably linked. So I think it was, there's various people who say they made this first quote, there is no health without mental health. But importantly, there is no mental health without social health as well. And I think we've got some inconvenient trends going on in Australia. So this is looking at data from Mission Australia and Growing Up Digital Australia. And you see that blue line going up is increase in screen time, pressure to succeed, homework expectations, income inequalities, education inequalities, and health inequalities. What's going down is mental health, physical health, digital wellness, eating healthy food, sleeping well, time to play, and engagement in learning at school. The other thing, and this comes out of the WHO Health Equity report, if we're going to improve health in Australians, only 10% of that will come through improving health services. Where does all our money go? It tends to go into hospital care, a lot into primary care, not a lot about linking the two. But if we really want to make a difference to health, that yellow-orange bit is income security and social protection, and the green bit is living conditions. And how much do we as healthcare practitioners really interact with that? Not enough, I would say. And so Australia's health is still largely determined by socioeconomic status, and we need to invest early, and this is not just my paediatrician bias, this is data-backed, and it's more effective and cost-effective. So the data in those graphs up in the top left is looking at the Australian Health Tracker, if you're interested in having a look, and that's tracking things like obesity and diabetes over time. We know they're rising, but we also know that there's a big socio-economic gradient there, with the most disadvantaged Australians being more likely to be obese or diabetic. Jim Heckman from the US won his Nobel Prize for showing the economic impact of investing in early childhood learning. And he's shown an 8% return for investing in the first 2,000 days of life from conception to 5 years of age. And the reduction comes because if you can get in early and get kids on the right track to good health and good education, then there's less need for special education, better health, less need for criminal justice and social services. And that saves money. But the hard thing with government is it saves money in the long term and not in a 3-year election cycle. So my next key mentors, I've been doing RCTs for 15 years and I really enjoyed them. And then Professor Gary Freed came to the University of Melbourne from the University of Michigan. And he was a paediatrician and a health services researcher. And I said, what the hell is health services research? Because I'd really just heard about quality improvement and sort of hadn't been that impressed. But he started talking about health systems and services, and he got access to Medicare data and tracked what was happening with our GPs over time. And he saw that fewer children were being seen by GPs because of the adult aged care population and GP time being taken up with managing chronic care. He also used Victorian hospital data sets to show an increase in primary care type presentations by children to our emergency departments. And then he surveyed parents and GPs and paediatricians about care. And so he really won me over, and I thought, I'm going to leave RCTs and I'll move over to health services research. But it's pretty hard to take the RCT out of the researcher, as you can see in a minute. So we set up the first Australian Paediatric Health Services Research Program at the Murdoch Children's Research Institute and the Royal Children's Hospital. And my partner in crime is health economist Professor Kim Dalziel, who's brilliant. And we have 4 key areas that we look at. And when I say children, you can take out children and put adult or whatever age group you like. But we look at models of care to keep kids out of hospital. How do we reduce low value, wasteful care? Do people know what low value care is? So that's care that is unnecessary and might do harm. So over testing, over prescribing, for example. We also look at improving access to mental health care, and Kim leads a whole program of work around improving our measurement of quality of life in kids, because that informs policy making and funding decisions. So I'm just going to focus in a bit on the mental health work, because I won't try and cover everything, but we got a few years ago an NHMRC grant because I was really concerned about kids' mental health, and luckily NHMRC was as well. And people have always said, oh, it's teenagers who get mental health problems, but that's actually not true. And our systematic review work has shown that adult mental health problems typically emerge around 5 years of age. So in preschoolers, we see externalising behaviours like aggression or opposition or defiance, or internalising behaviours, really anxious, scared kids who won't separate easily from their parents. And it affects their functioning at home as well as socially and in educational settings. We've only ever had 2 national mental health surveys of kids' mental health, and the last one was in 2015, and it was actually diagnostic interviews in over 6,000 households. And it shows us the prevalence of ADHD sitting at just over 7%, followed by anxiety and depression. And what some of the reasoning that we went forward to with the grant is everyone said, oh, if toddlers have got problems, they just grow out of it. But that is not necessarily true. So in a trial we did around anxiety in preschoolers, we went to over 307 Victorian preschoolers. We went and screened for really shy, inhibited kids, found 545 of them. And in the control arm, we tracked them over 2 years. 50% met criteria for an anxiety disorder when they hit school. And 42% still met criteria for an anxiety disorder 2 years on. And the modifiable factors were over-involved protective parenting and poor parent mental health. If we go even earlier, this was a study I did in the Victorian community with Fallon Cook, and we were surveying just over 700 Australian mums of 8 to 12-monthers. And we were following them over time. And if at 12 months they had persistent sleeping, feeding and crying problems, their odds of having a mental health problem at 5 and 11 years were 9 to 10 times more than the babies who didn't have persistent feeding, sleeping, crying problems. So we put a lot of money into teenage mental health, but we need to start way earlier. So who gets help? Who misses out? And this is data from the longitudinal study of Australian children, so 5,000 kids linked to Medicare data. So this is health services research. Oh, there we go. And we can see that lots of kids aren't getting any help for their mental health. So in these children from 8 years of age to 13 years of age, between 9 to 27% are getting a Medicare rebated mental health service. Who's missing out? Girls, younger children, and those from non-English speaking backgrounds. And then this is looking at those kids over time and tracking their mental health. And we can see there's kids with persistent mental health problems. They're getting care, but they're not getting enough. So we decided it was time to check the children. And we did interviews with parents and clinicians, which I'll talk briefly about. I won't talk about the secret shopper study, but we had a medical student ring over 380 practices, or paediatricians, psychologists and psychiatrists, pretending to be a mum of a kid with a mental health problem who was age 11, and said, how long do we have to wait to get an appointment and how much is it going to cost? And this was pre-pandemic and it was already pretty horrific, and a third of clinicians had closed their books to seeing any mental health problems in kids. Anyway, so we did interview families and clinicians across Victoria and South Australia, and we said, what are the problems, what are the challenges, and what are the solutions? And Richard, when you're talking about, trying to present stuff simply, this is 3 years of data into one infographic, and I'm very thankful to the knowledge translation team at my work to be able to do this. So this is the challenges, but it's also the pathways to improving things. So the first challenge is that particularly the GPs said, we can't tell if it's a mental health problem or not in a kid. We don't know if they've got a problem or they're going to get better. When we decide it's a problem, we don't know where to get help. If we do, there's long wait times and costs, care's fragmented, there's no help for the parents or the siblings, and there's just not enough care. So I'm not going to go into these in details, but the 3 solutions I've been working on to try and address this is here. So Compass is our Connecting Mental Health and Paediatric Specialist service. It's in its 4th year. We stood it up during COVID, and it's an online community of practice run by the child psychiatrists at the Royal Children's Hospital for the local GPs, nurses, paediatricians and psychologists. He also provides primary and secondary co-consultations, and we've shown improved clinician competence, reduced burnout and fewer referrals to our mental health system when Compass is running, with a return on investment of $1.86 for every dollar spent on that program. We've just finished a big partnership grant called Strengthening Care for Children in metropolitan Sydney and Melbourne, with 130 GPs and 21 practices, where we put a paediatrician half a day a week into the GP practice, and the paediatrician saw kids with the GP and strengthened the GP's care. So we've seen a reduction in referrals to the hospital. Remember when I talked about the ED and outpatient clinics? We've got over 12 months waiting list for our general medical outpatient clinic at the hospital. And we've also reduced referrals to private paediatricians, and that's really important because they cost a lot of money out of pocket and not all families can afford that. And we're just wrapping up our Centre of Research Excellence in Childhood Adversity, which is funded by NHMRC and Beyond Blue. And that was really looking at the social determinants of health and their impact on kids' mental health and trying to get in early. And we've built one-stop shops for families in Wyndhamvale in Victoria's West and Marrickville in New South Wales, where families walk through the front door of a health clinic, but in there we've embedded lawyers, financial counsellors and social prescribers. So we're really trying to look holistically at the social determinants of health and mental health and address them via integrated care. So this is my last slide. I'm really pleased. Compass won the Victorian Public Health Care Award late last year for the support of the workforce. And to keep things interesting for me, I've taken on a role in a spin-out company from MCRI called MatterWorks, which is run by 2 women who used to work at the AFL, nothing to do with health. But they're taking all our research that appears in conferences and academic papers that no parent ever reads, and they're putting it into digital edutainment formats with the messages, and our first program has been around kids' mental health, the messages delivered by sports stars and social media influencers and people like Chloe Hayden from Neighbours. So that's really fun because it's translation in a different way and it's really agile and you don't need ethics. So summing up, it's a real privilege to be a clinician scientist. You help hundreds of thousands of people, you work with other disciplines, you travel the world, you meet great minds and you feel like you're making a difference. There's inevitable rejection, the briefcase is full and it's a pretty hard slog, but it keeps really life interesting and I've been fortunate to move beyond health towards integrated care, policy and now innovation in the business world. So thank you.
Thank you very much. We might open the floor to some questions now. Maybe I'll start by asking you, I think briefly you mentioned at the start in terms of early in your career and having a partner, or starting to establish a family, and you highlighted something about finding someone in your area that you resonated with or and sort of approaching them as a mentor. Perhaps for our audience, if you'd like to speak to that more and how that's influenced your career has sort of...
Yeah, look, I think it is challenging. So I had a partner who's also a doctor, which made life a bit easier, and he was not doing any research at the time, although I say he followed in my footsteps and he's done a PhD. But it was really important that there was someone who could help share the balance of looking after my kids and would be understanding if I needed to go off and do an international conference and be supportive of that. And you do take a bit of a pay cut when you do a PhD, so you go on to a tax-free stipend, which is something, but it may not be the same as what you've been earning clinically. So I had that, and I had a really strong role model in Melissa Wake, who she was Elizabeth Blackburn Fellow for NHMRC a few years ago. She's just got an amazing mind, but she was also there to say, if you need to have time off for your family, that is okay to do. So she I don't know if she role modelled a work-life balance because she works so hard, but she role modelled that it was possible and it was flexible. Mm-hmm. And my husband was in the ED doing shift work, so I knew his hours and his roster, and we could work around that. But one of my colleagues did give up on her PhD after 1 year because she didn't have a partner who was supportive. And I think you have to have that conversation. And I'm going to be very gendered here, but I think as a female, you need to have that conversation because the role models of, the man going out to do the PhD and having that career and being supported by a female partner, I think have changed. Mm. Yeah.
Thank you.
Lunchtime, everyone brain dead.
Thank you so much for your talk. You alluded at the end of the talk about the importance of engaging the public with the research that we do. In terms of our evolving nature with social media and stuff like that, how do you see ourselves engaging the public more meaningfully and also gauge a response from them about the importance of how we do our work?
Yeah, that's a great question. And I think we don't get a lot of training in that. We sort of learn it organically. If you're working anywhere that has a media unit or a comms unit, go and talk to them. Go and make friends with them. So often they're in the hospital or they're in the university or the research institute. Email them and say, I'm really interested in learning more about how this works and how this doesn't work. There are some online courses around how to use, social media for impact in your research, which is worth looking at. MatterWorks is completely different because they are a company and they look at distribution channels. So we partner with ABC Education, for example, or I'm going to the Gather Round in 2 weeks with the AFL to talk about mental health because they have a whole, kids program in mental health. So I think it's thinking outside the box. It's looking for training opportunities that might be through your university, but go and speak to your comms people and they'll be probably surprised but delighted because that's what they've done their degrees in and they'll be more up to date often than what we are. Yeah, great question.
We have managed disinformation in social media system like.
Oh, that's absolutely massive. And that's why I joined MatterWorks, because their campaign is to make sure everything they do is researched, informed and evidence-backed. Because misinformation in mental health, there was a study looking at a year's worth of information and 87% of it was incorrect. I think the only way we can do it, though, in a way that the audience who we want to listen will listen, is by using social media people and sports stars, actors, actresses, etc. Unfortunately, I think if we get up there and say stuff, it's not necessarily listened to. So, for an example, I was speaking to my goddaughter the other day who vapes. I said, you know what that's doing to you? She goes, no, it's okay to vape until you're 24, and then as long as you stop then you'll be fine. I thought, she's doing law. She's a smart girl. And me telling her is not going to make a difference. So we're just putting in with the Vic Health grant to try and do some work in Hastings and Frankston around vaping, but using sports stars, social media influencers as the people to relay the facts and the evidence. It's really challenging though. But if we're not using that, I don't think we're going to get anywhere. Well, particularly for youth. Yeah.
Thank you, Prof, for a great talk. You touched on social determinants of health and how nuanced that can be with the social and economic factors that can impact patient care, I guess. And from my short time in medicine, I'm realizing that a lot of the clinical practice or the treatment that we offer patients is based on guidelines that are informed by research. But as we heard from Prof. Stanley this morning, a lot of that research can sometimes be on a very privileged subset of people. So I guess my question is about how do we make research more equitable and on an individual and organisational level?
That's a small question. Fantastic, though. And I don't think we have to throw out guidelines. As a talk yesterday, someone said we don't need to reinvent the wheel, but we do need different hubcaps. So you don't have to throw out everything, but you do need to be for context, for culture, for place-based. To make research more equitable, funding still drives research. So, you might have a great idea, but often we're reacting to a grant call. And to be honest, and that's when you get people to come together and work together. And so if that becomes part of the metrics of a grant call, whether it is from NHMRC or MRFF or philanthropic, bodies often do this really well. And I think that's the same with lived experience. So calling out in the grants, this is what we're going to value, we're going to mark you on, that will start to change things. I think we also, it is hard, and I do this, we go and do our trials with people who can speak English, who turn up to a service. It's really hard to go and find the people who don't turn up to a service and to get the funding to, be able to translate. And we always go, well, we need to test it first in this population, but we never necessarily go on to the next population. An exception I saw in that was Northern Health during the pandemic, and they did a fabulous job, and their interpreting service gave their time free to doing some really good COVID research to find out that, not surprisingly, a lot of people were getting their COVID information from their country of origin, and it wasn't fit for purpose for what was happening in Victoria. But that was someone driving it to do it, but I think we need to be thinking about writing it into our grants and having specific calls to call that out. And I think it's a great opportunity for translating what we know works to see if it really does work, and do we need a whole new wheel or do we just need to replace the hubcap?